boys, there is a small peak around the age of 2. Up to 60 to 70% of the tumors are benign. Therefore, the intraoperative frozen section should be available during the surgery. The organ-sparing surgical approach is preferred in benign tumors, whereas the malignant tumors, standard orchidectomy is correct. So, usual clinical presentation is a painless scrotal mass in more than 90% of the cases. Some patients can present with the vague scrotal pain, and others there are small amount of patient can present with the hydrocele also. The boys with the early onset of puberty, such as the as well as the high testosterone and the low gonadotropin levels, need to suspect the Leydig cell tumors. The evaluations, it's a high resolution ultrasound examination having a detection rate of almost 100%, and the tumor marker we need to when we are doing the tumor marker, age should be taken into account. So alpha-fetoprotein has a clear limitation of its sensitivity and specificity in the first months of life, produced by more than 90% of the Jock tumors. And teratomas also produce alpha-fetoprotein, but not that extent of the Jock tumors. So alpha-fetoprotein should be measured before any therapeutic intervention. So has a serum biological half-life of 5 days and should be measured 5 days after the tumor resection or orchidectomy in those with the elevated alpha-fetoprotein. So beta ECG is derived from the chorion carcinoma, internal carcinoma, seminoma. These tumors are extremely rare in prepubertal boys, and therefore beta ECG is not useful in prepubertal boys. So no urgent need for the preoperative staging, as there is no consequence before the definitive histology is available. So management, so the orchidectomy could be considered only if the normal testicular parenchyma is no longer detectable in the preoperative high-resolution ultrasound, or the patient with the alpha-fetoprotein more than 100 in a more than 12-month-old boy, we are highly suspicious of Jock's active. For the surgical technique, the panel in favor of the inguinal approach. There is no evidence in the literature that tumor spread is prevented by the clamping the vessels before tumor mobilization. Whenever the the testis-sparing surgery should be performed along with the frozen section during the surgery to confirm the diagnosis and to confirm the microscopical imaging negative resection is performed. In patient with the malignant tumor, the Jock's tumor, immature teratoma, staging should be performed including the MRI abdomen and the CT chest. If there is any suspicion of non-organ confined tumor, the patient should be referred for the chemotherapy. In benign tumors, mature teratoma, epidermolysis, no further staging is required. The tumor entities in prepubertal babies, commonly the teratomas, usually the benign in prepubertal children, and represents the greatest proportion of the intratesticular tumors, around 40%. They present at the median age of 13 months, and only in adolescent and the adults, they should be considered as a malignant tumors. So, an ultrasound examination, heterogeneous fixes with some calcification is seen, and the alpha-fetoprotein should be less than 100 nanogram per milliliter in India. The organs, we can consider the organ sparing side. The epidermolysis is an ectodermal origin and seems to be related to the well-differentiated teratomas, and the keratin-producing epithelium is responsible for the keratinized squamous epithelial deposit, which appear hyper-echogenic in ultrasounds. We can consider the organ sparing side. The juvenile granulosa cell tumors occurs usually in the first year of life, typically within the first 6 months. And the management is organ sparing. And the Leydig cell tumors is suspected in boys with the early onset of puberty with the highest testosterone, high testosterone and the low gonadotropin level, usually between the 6 to 10 years of age. The Sertoli cell tumors, around 1/5 of the Sertoli tumors occurs in children, usually within the first year of life. Occurs in patients with complex dysplastic syndrome such as the Carnio-Porcellius syndrome. Where we can consider organ sparing surgery. The Jock tumors is predominant prepubertal malignant germ cell tumors and may present around 15% of the prepubertal tumors in boys. Usually within the first 2 years of life, up to 80 to 85% of the tumors are organ confined, and the tumor usually spreads hematogeneously chest. The overall 4 year survival rate is about 98%, and follow-up with alpha-fetoprotein 2 to 3 monthly, and the MRI of the abdomen is recommended at least for the first 2 to 3 years, because about 20% of the stage 1 cancers develop the metastasis in the 2 years. In case of recurrence, consider chemotherapy. Follow-up, the regular ultrasound examination is recommended in the follow-up period to detect any recurrence, and the abnormalities 3 to 6 monthly within the first year. Follow-up in patient with the Leydig cell tumor should include the endocrinological examination. The database, the 5-year relative survival for the testicular malignancy for less than 14 years of age diagnosed with the localized testicular cancer is about 98%. For the distant disease, about 70%. My next topic is the acute scrotum in children. The common differential diagnoses are the testicular torsions and the torsion of the testicular appendages, and the acute epidermolysis, idiopathic scrotal edema, HSP, and incarcerated hernia, testicular tumors, and sometimes with the varicose. The testicular torsions, the pathogenesis is mainly patient presented with the pain, with the ischemic pain because of the twisting of the cord lead to the ischemia. The twisting of the cord can be intravaginal or the extravaginal. Extravaginal is almost exclusive during the perinatal period. So most of the time, the etiology is unknown, but the patient with the testis with the transverse they are some more prone to get torsion, and maybe there is a hormonal influences because the most of the patients are present in the adolescent period around the puberty. The epidemiology, the true torsion is found only about the 1 in 4 of export cases, and the peak times it can occur at any age. A relatively two common time periods are the perinatal and the adolescent. The diagnosis, the final diagnosis, is actually at the time of the exploration. The usual history with the acute onset of unilateral scrotal pain, the severe in nature, and occasionally associated with the vomiting. The examination, we can find the tender testis, erythema, and the swelling of the hemiscrotum with the high-lying testis on the horizontal portion compared to the opposite side. And the movement exacerbates the pain where contrast to the epidermal gait is where the elevating the testis causing relieving the pain and the absence of domestic reflex. The ultrasounds of the testis and the cord, the vascular flow within the testis is diminished and the difficult to confidently explore the torsion most of the time. Support sensitivity about 70%. The management, so the manual detorsion of the testis is done without anesthesia, should be attempted in all patients if possible, because it's associated with the improved surgical salvage rates. So it should initially be done outward rotation of the testis, like opening a book, unless the pain increases if there is obvious resistance. Success is defined as the immediate relief of all the symptoms of, and the normal findings is the physical examination. We can use the Doppler ultrasounds as a guide, and followed by the bilateral oculopexy should be required. The surgical treatment, so the urgent surgical exploration is mandatory in all cases of testicular torsion within the 24-hour of symptoms onset. And in patient with the testicular torsion, where that more than 24 hours, exploration may be performed as a semi-elective exploration procedure. So in neonates with the signs of testicular torsion at birth, duration of the symptoms will not clear. The decision to perform the surgical exploration should be weighed against the general condition of the child. During the exploration, fixation of the contralateral testis is also performed. The recurrence after the oculopexy is less than 5%. The common complications following the surgery are the wound infection and the infection of the necrosis may need the re-exploration, the scrotal hematoma. The follow-up, the two testicular torsion should be reviewed in 2 months to document the survival of the untwisted testis. If the orchidectomy was performed, we need to discuss about the testicular prosthesis and the fertility, the normal pregnancy rate after the unilateral testicular torsion with no difference between the patient undergoing the oculopexy and those after the oculopexy. Then the other common acute scrotum to the present to the emergency department is the torsion of the testicular appendages. The diagnosis are less acute and the less severe than true for the testicular torsion, and the examination. So that usually the tenderness is confined to the area or the one upper pole of one area only, but eliciting this is very difficult. So if the minimal overlying skin changes, blue dot may be seen in the upper pole of the scrotum. If the long-standing erythema and the swelling cannot. So management is when we are confidently say it's a torsion of the epidermal appendages, we can leave it alone with we can manage with the analgesia. But most of the majority of the cases difficult to exclude. So we need the recursive surgery, and also the patient also prefer the surgery to relieve the pain quickly. And when we found the torsion of the appendix, we can remove the appendix, and we don't need to fix the contralateral disease. So usually no need to follow. And the idiopathic scrotal edema, so usually the cause is unknown. The presentation mostly in the pre-pubertal age group, and patient present with the traumatic erythema and swelling of the scrotal skin. So erythema is typically extends across the midline. It's crucially noted. The management is conservative, reassure the family, and some prescribe the antihistamines. So my other scrotal condition is hydrocele, where the abnormal collection of fluid in the process vaginalis that fails to obliterate, which leads to patent process vaginalis and swelling in the scrotum or the groin. So exact time of the spontaneous close of the process vaginalis is not known. They persist in approximately about 80 to 90% of the newborn and in about the 20% of adults. The complete obliteration of the process vaginalis occurs with the patency of mid portion called as a cyst of the cord. The non-communicating hydrocele, based on the imbalance between the secretion and the reabsorption of the fluids, can be secondary to the minor trauma, testicular torsion, epididymitis, varicocele operation, or the hernia. So usually it's in about the 5% of the term burst boys, and by the 2 years, 90% will have resolved. So clinical features can spurt about the brain swelling noticed by the appearance and increase with the viral infection towards the later part of the day. And examinations, overlying skin with the blue tinge, and if the tinge, the testis is impalpable, can usually get above if the infantile cannot. And the answer minute, but in the in the children, the inguinal hernia also can transfer vein. The ultrasound is indicated if the testis is abnormal during the palpation. Some majority of the infant surgical treatment of the hydrocele is not indicated within the first 12 months of life because the tendency for that spontaneous resolution. So yeah, the early surgery is indicated if there is a suspicion of concomitant inguinal hernia or the underlying scrotal pathology. The persistence of simple scrotal hydrocele beyond the 12 months of age may be indication for the surgical correction. So late onset of hydrocele suggestive of non-communicant hydrocele. There is a reasonable chance of spontaneous resolution is about 75%, and the expected management of 6 to 9 months is recommended. In the pediatric age group, the operation consists of the ligation of the patent process vaginalis via the inguinal incision, and the distal stump is left open, whereas the hydrocele of the core and the cystic mass is excised or unrolled. So the incidence of testicular damage during the hydrocele or the inguinal hernia is very low. And the scrotal approach, the load or Jebolis technique is used to treatment for the secondary non-communicating hydrocele. The varicocele in children and adolescents, the varicocele is defined as abnormal dilatation of the testicular veins in the pamphiliform plexus caused by the venous reflex. This unusual in boys under 10 years of age becomes more frequent at the beginning of puberty. It is found about the 14 to 20% of adolescents with a similar instance during the adulthood. It appears mostly on the left side. The right side is very rare. The varicoceles can induce apoptotic pathways because of heat stress, androgen deprivation, and the accumulation of the toxic materials. In about 20% of the adolescents with the varicocele, fertility problems will arise. We can classify it into the
time is over. Can you wind up, please?
Only 2 slides. The grade 1 is Valsalva positive, and the grade 2 is a palpable, and the grade 3 is a visible. So varicoceles being mostly asymptomatic can present with the racking sensation of scrotum, and the clinical findings of collection of dilated and throatus veins in the upright portion and more pronounced when the patient performs the Valsalva method. The diagnosis using a Doppler ultrasound color flow mapping in the supine and the upright portion with the Valsalva. The recommended indication criteria for the correction of varicoceles in the children and adolescents are varicocele associated with small testes. These should be confirmed on a 2 subsequent visits performed in a 6-month apart. The additional scenario where the varicocele treatment can be considered on the symptomatic varicocele. The pain is about present in the 2 to 10%. Where the patient should be informed that pain can persist after varicocelectomy in a 20% of the cases. And the bilateral palpable varicocele, pathological sperm quality in old adolescents, and cosmetic reasons related to the scrotal swelling. The management or the surgical management with the ligation is performed at the different levels, usually with the inguinal or subinguinal, with the microsurgical is a standard gold standard treatment option, and the suprainguinal ligation using open or laparoscopic techniques. And the radiological management is the antegrade or retrograde sclerotherapy, and the retrograde embolization. There is a low to moderate level of evidence that radiological or surgical treatment of adolescent varicoceles is associated with improved testicular size or growth and sperm consumption.
Thank you, Pragaladan. You have done the more descriptive presentation. Within 20 minutes is very difficult you to do that. Thank you for try to finish in time, but we will go for an expert opinion and the expert questions. Sanjay sir, you can ask questions from the presenter.
I think it's a very comprehensive presentation under the limited, time period given and a large number of topics to be discussed. Yeah, it was wonderful. So I think on the undescended testes, I think for now the Fowler's even impalpable undescended testes, and if it is high at laparoscopy, then you might have to go for a staged procedure. There is this Shehata technique, where you anchor the testicle on the contralateral inguinal, near closer to the anterior supinoid spine, and then wait for 6 months or probably about 3 months, and then go in and do it again is also catching up. Actually, we also have now shifted to that because this Fowler-Stevens procedure, although you have a testicle or you have a palpable testis at the end of the procedure, in the majority of cases, we are not so sure about the functional preservation. So, because we have made it quite ischemic at the time of ligation. There was the Shehata technique, if you read up, it's widely available, the operative techniques and all. It's also better to know that a little bit about that as well. And then I think most of the others you've covered quite well and comprehensively. Paranga, is there anything that you can add?
Yes, as you said, very comprehensively covered. What do you think about doing detotion, manual detotion for?
Yes,
We really
I've
don't
never
practice
done
it
that. I
now,
mean,
so
yes, I've been somebody who has palpated a child with a, torsion of a testis, even to, just touch it is so difficult. Like people will not even allow you to get close to. So I have never kind of attempted the detorsion, but it looked quite a nasty procedure. So these days,
yes.
so I have you seen anything like that being done there?
Yeah. No. Anything that'll cause pain or discomfort to a child, even if you mention it in the exam,
Yes,
that's
that will be
really.
yes. Yes. That was
And one more thing I noticed, the guidelines for intervention of varicocele in adolescents, as far as I know, have changed. We recently had a journal discussion about it about 2 weeks ago. If you could just go through the indications again, the size discrepancy is not used as indication anymore because they have found that uh, almost like 90% of adolescents, when they go through puberty, the size discrepancy catch up. I mean, there's a catch up growth, irrespective of the fact whether or not they have a varicocele. So there are I think few indications have changed. Pain and symptoms, of course, is an indication. But if you go through the EUA guidelines, the latest urology consensus on management of varicocele, it'll be there.
So you're going more and more against,
Yeah.
intervention. Yeah. And
Yes.
similarly, the PPB, so we ligate the PPB, just like inguinal hernia, have the deep inguinal ring. And of course, in inguinal hernia, you leave the distal sac, if it is inguinal-scrotal hernia, open. And of a PPB, you generally empty the sac and open the distal part of it a little wider, so that whatever contents empties. But even if you leave it alone, it will absorb. So there is so both cases, it's very important that the deep inguinal ring, the PPV or the inguinal sac, is ligated at the deep inguinal ring. Flush, yeah.
Pragalathan,
Yes.
you talked about different, definition for different types of testes. Do you know what is gliding testis and ascending testis?
Gliding testis, where that because of cremastic reflex, it's going to the suprascrotal position. Sir.
Is retractile testis, no? Because of the cremasteric reflex, the testis is retracted. So it can be brought down without pain or without tension. So if we want to drag it with tension and there is pain, that is called gliding testis. And ascending testis is some of the retractile testes, they were down in the scrotum and later on they are ascending. So they need fixation. So retractile testes, they do not need intervention, but gliding and ascending, they need intervention. And the other thing, that varicocele grading, you said about 3 grade, there's a subclinical grade also, grade 0.
Yes.
So don't forget that. And the other one, when would you decide whether you are going to go ahead with Paul-Stephen 1-stage or 2-stage surgery during the laparoscopy?
When usually when the testis cannot be bring it down to the opposite side of the deep ring, that will say it's difficult to brought down to the scrotal side in the 1 stage.
The opposite ring, yes. And the other thing is that always in acute scrotum, you have a low threshold for exploration. For sake of interest, do you know any scoring system? Like appendix, we have this Alvarado any scoring system? Because recently they have presented that paper. There's a twist scoring and ball scoring. Just read around this, just to, nice to know things. Sanjay sir, shall we move on to the next talk, sir?
Yeah, we will, yes. Let's get on, yes.
Okay, the next talk will be on penile condition in peds. It's going to be presented by Dr. Tivika. Tivika, over to you. You have 20 minutes.
Can you hear me?
Yeah, loud and clear.
Okay, thank you. So this is my topic, pediatric penile conditions. So before talking about the pathological problems, we have to know something about the embryology. So as we know, during intrauterine life, initially it was undifferentiated genitalia. So with the help of the SRY gene on Y chromosome, there will be production of dihydroepiandrosterone. So with the help of androgens, then it will be developed into the differentiated genitalia. So the phallus will be forming around 9 weeks, and with followed by the formation of urethral plate. So if there's any deficiencies in the androgen, or if there's the arrest during the embryogenesis, we can get all various problems. And foreskin also starts to form around 13 weeks of intrauterine life. And initially it starts from the corona and then finally up to the urethral orifice. So in intrauterine, it's completing about 18 weeks of intrauterine life. So if there's arrest, again, it can give rise to hooded prepuce. So first, I will be talking about the phimosis. So as we know, the phimosis is inability to retract the foreskin. So there are something called physiological phimosis and pathological phimosis. So physiological phimosis at birth, almost the physiological phimosis will be present. That is because of the additions between the prepuce and the glands. So as the child grows, then there will be accumulation of sloughed epithelial debris or smegma that will facilitate the formation of retraction. That will facilitate the retractile foreskin. So the physiological phimosis, usually it's about 90% of the boys will have at 6 months, 50% at 2 years. With time goes on, it will be about 1% at 16 years. So what we call pathological phimosis is when the phimosis results from balanitis erotica obliterans, or it can be we will be talking about balanitis erotica obliterans, or occasionally it's because of the traumatic forceful retraction of physiological phimosis or recurrent balanitis, or it can be also associated, it can be the result of incomplete or inadequate circumcision. So the treatment is, we had to discuss with the family, we had to explain to the parents and reassure them, because they will be thinking it's pathological. So we had to explain them about the physiological phimosis, and we can advise about gentle retraction. So this is gentle retraction also should be done by the child, not by the parents. That is to facilitate that is to facilitate the retraction. And we can also try low dose steroids. Failing that only, we had to, in extreme cases only, we had to go for circumcision. Because if we are going for circumcision, there should be a pathological reason or pathological phimosis. Or if the physiological phimosis persists even after 16 years or around near the late childhood, we can go for circumcision. So balanitis erotica, coming to the balanitis erotica obliterans, it's an idiopathic scarring condition of the prepuce. So it is if it is untreated, it can involve the glands and distal urethra, giving rise to meatal stenosis as well. Although it's very rare in children, but in older boys, it can happen. So if clinically we can see as a gray white scar at the introitus of the foreskin, and it's immobile because it's non-retractable. In children, the malignancies is very heavy. They have not been any case reports so far, but in adults it's a pre-malignant condition. So if it's an absolute indication for circumcision, and following circumcision also there's a 10% risk of meatal stenosis. Then this sperma then the then the sperma cyst. So sperma cyst is the begin the, so we can understand it's because of the physiological process of so the separation of the prepuce from the glands. So when there's a separation, the formation of the slough or deepithelial tissue, it can form between the glands and the skin. So that will be seen as the cyst outside. So with its, we can manage conservatively. With time, it will, with the enlargement of the cyst and the separation of the preputial adhesions, the sperma will discharge and followed by the prepuce also will be retractable. Then coming to paraphimosis. So paraphimosis, as we know, it's a when there's a uh, uh, when there's a non-retractable foreskin acting, giving rise to edema proximally, it can cause paraphimosis. It acts as a constriction ring. So the management is, we had to reduce under local anesthesia or general anesthesia. If that fails, we can go for a dosage split. And then something about buried penis. The buried penis is that includes various conditions like congenital megaprepuce, concealed penis. All these can be categorized. All these can come under buried penis. So congenital megaprepuce is something where the child will have the abnormally hypertrophied megaprepuce that can appear, that can give a situation where the child will be having buried penis. The concealed concealed subcutaneous penis is because of when the child is too obese or when there's excessive weight gain near the puberty, that can give rise to concealed penis. And again, we had if we are planning circumcision is a relative contraindication for circumcision because that can invariably worsen the situation. So congenital megaprepuce, it's because of there are theories, because of the improper penis scrotal transposition, or it can be because of the penis scrotal web, where the penis, too much of scrotal tissue is attached to the distal, the proximal part of the penis, and it can, because of that, it can appear as a buried penis. So again, it can cause problem because of the because of the massively hypertrophic prepuce. It can give rise to urinary obstruction, and it can cause ballooning. So if it is the patient is symptomatic, we can go for a ventral slit or a ventral side plastic, plastic. Then the consider subcutaneous penis. Again, we had to, again, the reassurance is the most important thing. Again, circumcision is contraindicated in this situation. So then we had the penoscrotal webbing. This is the penoscrotal webbing. Usually there's a normal penoscrotal angle is there. So when there's a web passing from shaft to the scrotum, again it can give rise to buried penis, or it can give rise to the parent concerns. So if we can go the treatment again reassurance, so we can go for a set plastic.
Okay, Dr. Prasanna, are you there with us? The next speaker, we can, if Devika is not there, we can move on to the next talk, and when she comes back, we can connect her. Devika, are you there now?
Devika is not there, Taha. We will move to next and we'll
Yeah,
give
please. Yeah, please, Dr. Munipriya. Yeah.
Dr. Satyamurthy Prasanna, you will discuss about the PUJ obstruction and the posterior urethral valve. Prasanna, over to you. If the connection is if connection is not clear, you can switch off the video and continue the presentation. Then we can listen to you. Over to you, Prasanna.
Sir, can you see my slides?
Yeah, yes, Prasanna. Yes.
Good evening, all of you. My today topic was uretropelvic junction obstruction, that PUJ obstruction and posterior urethral valve. As the both PUJ obstruction and posterior urethral valve presentations are different presentations are there in the pediatric population, but as the freely available ultrasound these days, main presentation is the antenatal hydronephrosis. So in the identification of antenatal hydronephrosis. So when we look at the causes for antenatal hydronephrosis, there are different causes. It can be a PUJ anomalies, that means the dysfunction of the PUJ, or anatomical abnormality like lower pole compression of the lower pole vessels, or vesicoureteric junction abnormalities like VUJ obstruction or vesicoureteric reflux, megaureter or uretrosis, and vesicoureteral anomalies like posterior urethral valve, urethral atresia, or urogenital sinus or cloacal anomalies, and like other some anomalies like collagen anomalies, prune belly syndrome, tumors, or neurogenic bladder. So when we look at the hydronephrosis in the antenatal scan, then there is a classification for according to the severity. So there are different systems are used. In the initial period, they use like a mild, moderate, severe. Like our now usually we use the term mild, moderate, severe, but then later on they develop the numerical system like less than 10 millimeter AP diameter or 10 to 15 millimeter or more than 15 millimeter. Then now after that, due to this interpretation variation, then they developed the SFU grading. That means Society of Fetal Urology grading. And finally, now using the urinary tract dilatation. That means UTD classification system.
Sorry for
So
the sorry for that inconvenience.
It's okay, Devika. We'll carry on with Dr. Prasanna's presentation. When it is done, we can switch back to you.
Okay, sir.
so once we identify the antenatal scanning with antenatal hydronephrosis, sometimes it can be a congenital one. So whether it is significant or non-significant, usually our protocol is if it is less than 4 millimeter in 33 weeks of gestation, or if it is more than less than 7 millimeter, if more than 33 gestation, those are non-significant. Then if it is significant one, then we can grade the antenatal hydronephrosis according to the either UTD or Society of Fetal Urology grading system. We can grade the antenatal hydronephrosis. The main importance of this grading in the antenatal period, mainly to determine the follow-up period, whether we are every month or every 2 weeks, we are going to scan the fetal ultrasound, because usually in our setup we don't have any fetal surgery facility. So our main aim of grading in antenatal hydronephrosis to follow up. So this is the actually the UTD antenatal UTD classification system. So either it can be UTD A1 to A3 is there. That means antenatal. So depend on these parameters, mainly the calcial dilatation and the cortical thinning, those parameters, they are categorized into UTD A1 to A3. So once baby is delivered in the postnatal period, then we have to repeat the ultrasound KUB. So when we are going to repeat the ultrasound KUB is the again problem that discussion one, because in the initial period within 48 hours of neonatal period, the baby is mainly dehydrated and the glomerular filtration rate also very low. So in the initial period within 48 hours of neonatal period, this usually not recommended for the repeat ultrasound KV. But if it is antenatally very severe hydronephrosis or baby's the renal abnormality, then we can do the within 48 hours. Otherwise, the recommendation is the ultrasound KV after 48 hours of birth. Then if there's a significant hydronephrosis, then next investigation is the micturition cystourethrogram or voiding cystourethrogram. Here we can identify the mainly the posterior urethral valve and the reflux VUR. Then we can go ahead with the dynamic renal scan. That means MAC3 or DTPA scan to identify the differential renal function. Then there's a MRI urography also available, but it's a superior anatomic detail. It gives the anatomic detail and the very no radiation exposure. But the thing is the need sedation. It's a time consuming and availability and the cost. Then there's a new biomarkers are the in the investigation, but it's still in the investigation part. The biomarkers to identify the early identification of the renal parenchymal status. So these are in the postnatal period. So in the postnatal period, there's a SFU grading is there. That means Society of Fetal Urology. There's a grade 1 to grade 4 is there. Again, same, the calcial dilatation and the cortical thinning depend on those things. There's a SFU grading. Same thing, UTD grading also there. Depend on those parameters. Again, UTD P1 to P3 is there. So again, the grading is why important. If it is low grade, then we can think about the follow-up. If it is high grade or intermediate grade, we can think about the early intervention. Same times, we can think about the antibiotic prophylaxis. So if it is UTD low risk category, that means UTD P1, we can no need the antibiotic prophylaxis. So that's the main important for this grading. So mainly recommended for severe hydronephrosis, mainly UTD P3. And if evidence of febrile UTI or culture positive UTI, then we can go ahead with the antibiotic prophylaxis. So when we come to the PUJ obstruction, so here we just discussed about the hydronephrosis part. When you come to PUJ obstruction, it's the most common cause for hydronephrosis. And these are the 1 in 1,500 or 2,000, and mainly male predominance. So main reason is the rather than anatomical abnormality, mainly they are the there is a fibromuscular and neural configuration. There's a problem with this peristalsis. So rather than the anatomical constriction, there's a fibromuscular and neural configuration problem. So it will ultimately lead to poor peristalsis and poor urine flow. Minor cases, there may be a extended compression with the low pole vessels or pararenal cyst or something. There may be a extended compression. So natural history, when we look at the natural history of progression, most of the PUJ obstruction will spontaneously resolve around 80%. So only 1/6 need the intervention. So our aim is to identify the who are the people need intervention. So we have done those investigations. So when the differential function is below 40%, then that's an indication for intervention. But if it is less than 10%, then no point of doing the intervention. Then we can think about the nephrectomy. So between the 10 to 15% of differential function, then again, there are different arguments. We can think about the nephrostomy tube, and we can again evaluate in the 3 months time with the DTP or MAC3. Then we can go ahead with the either intervention or the nephrectomy. So the main intervention indication is the differential function between the 15 to 40%. Then altered renal function. And pelvis AP diameter, transverse AP diameter is more than 30 millimeter. Again, this is not the absolute indication, it's a relative indication. If it is more than 30 millimeter, then there's a relative indication for intervention and symptomatic. So these are the indication for intervention. So the intervention surgical management, main management is the pyeloplasty, is the gold standard for repair. So there are many approaches are there. It can be open again, retroperitoneal or dorsal lumpotomy. This dorsal lumpotomy is the initial one. It's directly through the small incision over the dorsal area, and we can go ahead with the repair. And laparoscopic one is the again transperitoneal or retroperitoneal and robotic. So the original description is the Anderson and Hines approach. Usually, when we compare to the adult, here endopilotomy is the uncommonly used in children. It is associated with the lower success and high complication rate. So usually, endopilotomy we don't go ahead in children.
Dr. Prasanna, you have 5 more minutes.
Yes, sir. Then when we come to the posterior urethral valve, it is caused by the valve-like membrane in the posterior urethra, mainly at the level of the vermontanum, causing the obstruction. So most common for the blood outflow obstruction in the children, and it's around 1 in 8,000. And risk for CKD is around 32%, and end-stage kidney disease around 20%. So as previous investigation, this is the typical features of mixed MCUG. Here we can see there's a obstruction in the posterior urethra, and there's a Hampton and Young classification for posterior urethral valves. There are 3 types of posterior urethral valve, but mainly the type 1 and type 3 with a significant renal deterioration, and type 2 now it won't taken as a disease. So mainly the type 1, it's the commonest one, type 1, around 90 to 95% is the type 1. And the type 3 is mainly more significant one, because there's a only pinhole orifice is there. So it's mainly developed the renal dysplasia and the pulmonary hypoplasia. So when we look at the treatment for posterior urethral valve, so if we find in the found in the antenatally, so we can, if facility available, we can go ahead with the vesico-amniotic shunt or fetal cystoscopy and laser ablation, but design the high volume center. And postnatally, so once we diagnose, immediate management is the bladder drainage, mainly with a small catheter, mainly feeding tube with a 5 or 7 French feeding tube, rather than using the normal catheters. The recommended one is the feeding tube. If it is difficult, then we can go ahead with the suprapubic catheterization. Then once the baby is stable and the creatinine and renal functions are come to the normal level, or it's reducing, then we can go ahead with the valve ablation. That's either cold knife or diathermy, but the recommended one is the cold knife valve ablation. If the child is very difficult to go ahead with the endoscopic this ablative technique due to the size of the available endoscope, then we can go ahead with the vesicostomy. So directly we can do the vesicostomy, or even if there's any thickened bladder wall, difficult to go ahead with the vesicostomy or associated VUR, then there's a place for the high diversion. That means we can go ahead with the ureterostomy or even pilostomy. We can go ahead with the high diversion. Then ultimately, around at age of 17 years or 15 years, 30% required the kidney transplantation. And supportive management is antibiotic prophylaxis. If high-grade reflux associated with a high-grade reflux, then we can go ahead with antibiotic prophylaxis. And if it is associated phimosis, then we can arrange for circumcision. And early administration of oxybutynin, because with the PUR, posterior urethral valve, there's an associated bladder dysfunction. So to overcome this bladder dysfunction, we can early administration of oxybutynin is recommended. So unfavorable prognosis in the posterior urethral valve is the presence of oligogytrum in utero, and identification of the hydronephrosis before 24 weeks of gestation, and serum creatinine level more than 1 milligram even after bladder decompression or bladder drainage, high serum creatinine level. Identification of cortical cyst, that means bilateral cortical cyst due to dysplastic kidneys. Persistent diurnal incontinence. Due to this bladder problem, this child, they develop the bladder incontinence. So again, that is the poor prognosis. And pulmonary hypoplasia.
Thank you very much, Prasanna. We will move to the question. Sanjay sir.
Yes, so that's again very good, Prasanna, and comprehensive, presentation on PUJ and PUVAL. And I think one little point, I mean, so most of it is fairly well done about the various specifications and the indications for surgery and all those things. Nephrectomy, I think, yeah. So nephrectomy is nowadays done more and more, very rarely actually for non-functioning kidney, unless they cause huge problems like, say, hypertension. So usually it's a multidisciplinary team, the nephrologist, the urologist, or the pediatric surgeons will get together and think hard and say no. And, when it is really imperative that, if they get, because say if it is a refluxing non-functioning kidney, sometimes you get these, really bad recurrent infections that needs it. But PUJ obstruction, the non-functioning kidneys usually do not cause trouble, except sometimes hypertension. So if there is hypertension and if the nephrologists find it difficult to manage, then we would go for, because we have found, I think actually these happen by mistake. So there have been cases done, fortunately, mostly overseas. Now we have one in Sri Lanka also, where the normal functioning kidney was removed accidentally, and then these babies survived on these so-called non-functioning kidneys for years before finally needing renal transplantation. So because of that, just because they are so-called non-functioning kidneys on DTPAs and various isotopes and other imaging, we do not do nephrectomies, just lightly. So it has to be a really, really, you think hard and say no. And then when it is impossible, so it has to be a big event so that, then you don't do these unfortunate removal of the functioning kidney as well. So it can be a very big mistake, like doing it on the wrong side. But sometimes these cross-fuse ectopias can sometimes really mislead you, and then you start removing the non-functioning part of the cross-fuse without knowing. You might accidentally remove the other one also. So really, I mean, this is more than the exam. Take that message, so that whenever you remove a non-functioning kidney, think really, really hard and think 100 times, maybe a million times. Yeah. Okay. So don't take it lightly just because DTPA radiologists say, this is non-functioning. It might not be really. So unless they really trouble you, so they never trouble until the trouble troubles you. That really is true in this non-functioning kidney. So that's probably one take-home message. And I think the PU value is fairly well covered. So we see now, as you said, so we would pass the usually a feeding tube, a straight feeding tube, and almost always we manage to get it into the bladder, and then tape it with some micropore onto the penis, and it remains there for days and weeks until your creatinine levels come down. So not very long. I mean, so after a few days, when the creatinine level comes down and then the child is stable, so we usually try our 7 French cystoscope with the hook. It's 9 French actually. So we have smallest one with the diathermy. The cold knife is a 9 French one. So in very rare small preterm babies, we are unable to use that. So if you can buy a little bit of time with the feeding tubes, I try to avoid vesicostomies because I've seen so many of the downsides of the vesicostomy by other. So it's an individual thing, but some people go for vesicostomy immediately. But I generally try to do it only as a last resort, because most of the time you somehow manage to gently ablate these with the cold knife. We rarely use diathermy nowadays. Again, I mean, I've seen a patient who has undergone diathermy. So if you use diathermy, never use normal saline for irrigation, and use always dextrose for irrigation. So cold knife is the one that we use mostly at LRH nowadays. And so in those whose creatinine don't come down despite your ablation, then you might have to go with a vesicostomy. But most of those needs, as you said, now because of this bile bladder functional VUJ obstruction, you might end up doing a ureterostomy rather than a vesicostomy in those, because despite good stream and good flow, if the creatinine goes up, then a ureterostomy, and then of course subsequently various other interventions later on in life, like if it is a high pressure CC bladder, you might need to augment it and a whole lot of other things. But yeah, well done. Anything, Taranga? Anything that you can?
No, sir, I think you covered it all. Even at the place I'm training at the moment, they don't prefer vesicostomy diversions, given the same reasons, because of the complications, and also later a lot of them needing augmentations due to the unused bladder. Even the ureterostomies, they prefer to do refluxing ureterostomies to maintain bladder cycling. And another topic, the pediatric urologist's interest here is the pathophysiology of the bladder dysfunction in PU valve. I've come across few MCQs on that. And also, because there's a lot of antenatal diagnosis here, and the pediatric urologist is the person who goes and counsel the parents. There have been Viva questions in one of these Evelina sessions where they ask about how will you counsel a parent when they are found to have bilateral hydro at 22 weeks. So what they expect was the percentages of, how much of that will resolve, and what are the features suggestive of PU valve in antenatal scan. and also the prognosis of PU valve, like 1/3 will end up in CKD kind of information. And also like basically because fetal medicine is developed here, they are interested about the fetal interventions like vesicoamniotic shunting. So if we could read around that also, there can be questions.
Yeah, thank you, Tarang.
Could I ask a question? Can you all hear me? Yeah. For
Yes,
the
Yes, sir.
expert
Yes, sir.
panel and the speaker, congratulations on your presentation. What are the indications for ureteric reimplantation nowadays when it comes to vesico-ureteric reflux? Absolute or relative indications? Can you say it's none, or there are still any indications? So we are surgeons, after all.
Even if it is a severe reflex, we are not going to go for a ureteric reimplantation at first place. If it is a recurrent UTI, or if it is causing renal dysfunction, or if it is causing, if the patient, if there's a, even if the patient, if there's any social problem where the patient cannot access to the hospital, or so these are relative indication. Actually, there's no absolute indication. But even for the severe ones, we are trying to manage conservatively with the prophylactic. So recurrent UTI, renal dysfunction, in DTP failing with the continuous monitoring. If there's a if there's a renal dysfunction or if the failing kidney on the same side, then these are all relative indications. There's no absolute indication. That's what I think. So I'm not.
Expert panel has any views on that? What is secondary PUJ obstruction, secondary to VU reflux? Secondary PUJ. Is that an indication?
Taranga, you would like to comment?
Grade 4 and 5?
Here, of course, because of deflux injection, the management is changing towards intervention. So whenever a child with reflux, even less than grade 3, but coming with UTI or other symptoms or new scars on the kidneys, they just go ahead to do the cystoscopy and deflux injection, which is a very quite simple procedure with less complications.
Yeah, is bovine collagen, or what is deflux?
No, that is an innate
polymer.
Yeah, it's an innate polymer.
Okay. Right.
We recently looked it up.
So I mean, Teflon, everything was out now. I think the bovine collagen was
deflux. Yeah, it's a polymer. PTFE related to polymer.
Some polymer, isn't it? Yeah.
It's basically a debulking agent, and we have not had many complications.
Could you have obstruction and reflux both together in VU junction? Refluxing obstructed system, and how would you manage that? Suppose this kidney is still functioning. Is there an indication? Because there is a condition, rarely you get in a neuropathic bladders, it refluxes, but at the same time, if you do a DTP, you will find that it's a rising curve, and there's a UG obstruction as well. So there are a few indications are those. I think if you're suspecting infection, might have to correct them surgically, isn't it? And okay. And
4 and 5, of course, so that there is, you tend to move towards reimplantation, but as the candidate, one of the candidates said that it, you tend to go more with conservative management, but at the same time, when you go up the ladder, like grade 4, 5 with recurrent, infections, new scars forming, and then the parents and the child are not very reliable in taking the prophylaxis, all those things matter. So it's not a single, this grade 5 is reimplantation, grade 1 and 2 conservative deflux injection. But so and also I think this endoscopic injection is a very subjective thing. So those who propose it will use it widely, because they, there is always, it's a very individual thing. I think some surgeons will fit when they are proficient with it. Others will see the. I can remember last year we went for these urology or the WFAPs, that's the World Federation of Meeting at Qatar, and Professor Ransley, or I think Dr. Ransley from
Philippines.
yeah, saying that he has seen a few patients who have used these, even deflux. I mean, of course, the Teflon and all those things have now completely moved out, but even following deflux injection, they can end up having uretrovesical obstruction later on, say 20 years down the line. Some of them end up with no reflux now, but there is VUJ obstruction and very difficult situation.
Yeah.
So,
yeah. Philip is old school, so don't take everything seriously, right? He's even senior to us, so our teacher as well. So
yes.
I think probably he has to live long enough to find out the outcome of deflux and things like that.
Yeah.
Anyway, Ahanji, can I ask you, for the benefit of the trainees, when will you plan PU valve ablation? How long is the child going to carry the catheters and weeks and things like that?
Measure where if the baby is having high creatinine, the potassium rising, the anesthetists are not very happy to anesthetize. They think that there is it's a few days, usually at most week, I think, in most cases, unless the child is a very preterm child who you think that the cystoscope, by not leaving the catheter, like you see, leave these double J stents before ureteroscopy, they get a little bigger on the ureter. It's a bit similar. Sometimes when you have the catheter, it's a little bit easier. The smaller babies, cystoscopy is a little sometimes bit easier. We find it in some patients. It's subjective or not, but yes.
One more question. How do you assess the success of your ablation? This either hook or by Bugby? How do you know?
Proof of the pudding really is the fact that the creatinine levels should come down, and then the stream, the baby's the urinary stream will be. There is no objective way of measuring the stream, but lots of these babies just dribble drip by drip. No, but if they have a fairly good stream, and you can do that, just a bit of pressure, soon after. Also, lots of time now we get that, when you squeeze the bladder before the procedure, it will be hardly anything coming out, but after the procedure, if it is this, but so it's very difficult. Sometimes you have to wait a little bit until the creatinine comes down, but then you can always go in and do it. So you should not, I think, damage it too much and cause a stricture there. So we are a little gentle in the first attempt, but generally we go back in a couple of weeks later in any case, even if the stream is good, to see whether there's any residual valves, because nowadays the anesthesia is good and very little associated issues. But yes, so I tend to a little bit conservative in the first attempt than most probably, but we have seen a few cases of sometimes stricture. If you are really overzealous, sometimes you end up, I think even, some of them have now no valves, but there is probably sometimes, the ureteroscope doesn't go, cystoscope doesn't go through, not often, but so better to be safe than sorry, I suppose. Yes, so, but you can always go in and redo it. Yes.
Thank you, sir. That is always happy to have Neville sir on board. Thank you for joining with us. Dr. Prasanna, two things to add. You have to be knowing this O release curves, Holmes sign. So they might ask you to draw the types of O release curves in PUJ obstruction or nuclear studies. And nuclear studies also, we want to know indication, the types of nuclear agents, half-life, and things we want to know. Other thing you said about this PUJ obstruction indication for surgical intervention, it all depends on this natural study paper by Dillon, the diameter and the spontaneous resolution. So read about that paper also. Shall we move to the next speaker?
The previous one who couldn't complete, I think, shall we let her finish a little bit?
Yes,
yeah, Dr. Tivika, are you there with us?
Yes, I'm there.
Yeah, please, you can
quickly finish it. Yeah.
So, that this is a continuation. So the main pediatric penile condition is the hyperspadiasis. So as we know, the hyperspadiasis is the abnormal ventral position of the meatus. So when we are examining the child with hyperspadiasis, we have to look at the foreskin. There can be incomplete foreskin, there can be cody, and there can be meatal abnormality, which can be stenosis or megameatus. So these are the main things. These are the main things we have to
Sorry.
focus on examination. The prevalence is about 18 cases per 10,000, and the reasons can be there can be a familial association. So when there's a family member with hyperspadiasis, there's a risk of 7% of risk of getting another person getting hyperspadiasis, and there can be some endocrine disorders also associated. It's mainly the androgen insufficiency and low birth weight at birth, and OCP use after consumption also some described risk factors. The classification, so we can classify hyperspadiasis according to the anatomical location of the urethral orifice, which can be so we have three classification here. It can be proximal, intermediate, or distal. So distal is where the child gets the urethral orifice at glans or corona. The intermediate into the shaft. The proximal one, it can be penoscrotal, scrotal, and perineal. And the CV, not only this classification, this only includes the location of the urethral meatus, but more we have to consider other factors when it comes to severity. So we have to consider the penile length, available penile length, the size of the glands, and the shape and the quality of the urethral plate, and when it is associated, when it is not associated with cody, micropenis, or scrotal anomaly, again it's a mild form, because we can go for a state repair. And severe hyperspadiasis, where it can be a proximal ones, penoscrotal, scrotal, or perineal, or when it is associated with cody and the scrotal anomalies, we consider it is a severe hyperspadiasis. Again, the diagnosis is clinical. So at birth, we can diagnose by looking at the orifice of the urethral orifice, position of the urethral orifice, and whether there is any atretic urethra, the division of the corpus spongiosum, and the appearance of the hooded prepuce, and there can be scrotal abnormality. The patient can have penis, and there can be hoody, or there can be penile curvature. Again, the important thing is we have to look for other sinister features, because sometimes it can be associated with cryptorchidism. So again, 10% of the cases can be associated with cryptorchidism. So we have to see whether there's a undescended testicle, or it can be associated with open processus vaginalis. Again, if it is if there's undescended testicle or impalpable testicle with ambiguous genitalia, one should think about disorder of sexual differentiation. So we had to go for a karyotyping, and we had to go for a endocrine analysis, because it can be a congenital adrenal hyperplasia. So we had to consider this disorder of sexual differentiation if there's a undescended testicle, or when there's ambiguous genitalia. The
Devika, you
indication for
have 5 more minutes, please.
Okay, the indication for surgery, when it is a proximal hyperspadiasis, or when there's a meatus stenosis, or when there's a significant curvature of penis, and the rotated penis, hooded prepuce, penoscrotal transposition, split scrotum. These are the indication for surgery. The objective of the surgery is to bring the urethral orifice to the normal position, that is into the glands, and to form a new urethra, and and we have to consider the cosmetic appearance also. If it is a distal hyperspadiasis, we can, even if it is near the meatus, we can go for a meatoplasty. If it is the distal one, we can go for a one stage procedure, that is the tubulized incise plate procedure. And if it is a proximal ones, we can go for again the combination of tubulous incise plate procedure, and we can go for a two-stage procedure. So again, the same thing I described. So what is the place of preoperative hormonal treatment? they think so. If we are dealing with the proximal hyperspadiasis, if we are dealing with the small small glands, or if there's a short urethral plate, to improve the elongate the urethral plate and to increase the glans penis, we can give preoperative androgen that can be topical or systemic. So, but there are side effects of giving androgen, testosterone. The side effects are again can cause pigmentation. It can cause this hyperandrogenic some other features like skin irritation, increased erections, and the main importance from the surgeon point of view, it increases the perioperative bleeding and it impairs the wound healing. So therefore, if we are starting testosterone, we usually stop 1 or 2 months before the surgery. And so again, when we are going to the surgery, the age, so when are we planning surgery? So usually the surgery is done at around 1 year, 6 to 18 months up 18 months. And if there's a curvature, again, there can be CODY or there can be significant penile curvature. So usually when it is a CODY, it is because of the superficial skin connective tissue problem. So we can access the superficial connective tissue. But when it is significant, we have to go up to the corpora cavernosa. If it is a short problem, we can go for a corpora cavernosa flap repair, or we can go for if it is a significant curving, we might have to do some procedure to elongate the penis. So this is a well-described distal tubularized incise plate repair. When we have a patient with hyperspadiasis, this is the algorithm. So first, we have to exclude disorder of sexual differentiation. If there are indications for surgery, we have to first classify whether it's a distal or proximal. Distal, we can go for a TIP. Proximal, if there's no CODY, we can if the urethral plate is preserved, we can straight away go for TIP. And if there's a CODY or unhealthy urethral plate, we might have to go for a two-stage procedure. So again, during the procedure, we have to put a feeding tube or urethral catheter for the urinary drainage, and again circular dressing with slight compression and prophylactic antibiotic during the surgery as for any. And these are the complications we can get after the surgery. So there can be fistula, meatal stenosis, dehiscence, wound dehiscence, recurrent ventral curvature, hematoma, recurrence of CODY, stricture, and in later on life, these children can get LUTS, obstructive LUTS, and meatal retraction, and they can also get chronic pain. And there are some studies they evaluated about the sexual performance, but sexually there's not much impairment, but again the psychological discomfort or the psychological impact is there when they become adults. So again, long term, the follow-up should be there till adolescence to look for the complications such as stricture, voiding dysfunction, and the sexual problems, and any penile curvature or recurrence of penile curvature or diverticulum. And then something about congenital penile curvature. So there's something called congenital penile curvature where it's because of the corporal discrepancy. So because of some abnormal embryogenical arrest during the embryogenesis, they can get a congenital penile curvature. So you can manage conservatively, but if it is significant, when it is causing sexual problem, we can go for repair. And I have talked about all other penile problem, common penile conditions. And balanitis, again, it's as in adults. Balanitis, it can even, especially when the child is having physiological phimosis, they are more prone to get balanitis because of the irritation, and because of this sperma collection, they can get UTI. So we can manage conservatively. We can give some antibiotic. It's not a real indication to go for circumcision, but if it is recurrent balanitis or causing BXO, then we can consider circumcision. Thank you.
Yeah, thank you, Tivika, for that presentation on penile condition. Any questions or comments, Sanjay sir, Dr. Taranga?
Could I just ask one question? What is congenital short urethra. So this is one of the differential diagnoses of hypospadias. Congenital short urethra, because the surgery is going to be different if there is a congenital, because there is no Cody in that. Did you come across that situation? Congenital short urethra?
Yes.
Yeah, when you palpate, there is no, generally in hypospadias, you get, when you get Cody, in the midline, there is a string of, hard urethral plate, fibrous urethral plate. Congenital short urethra, you don't get it. So when you are doing the surgery, you don't have to correct the Cody. The moment you release the urethra, the cavernosa will be straightened up. So you don't have to cut in the midline to straighten the Cody. So there is a practical importance in identifying these two situations.
I have a question to Nils and the panel. How to measure the stretch penile length? Because some parents come with telling that the penile length is shorter, and there are definition for penile length. How to measure the penile length in our setup?
Actually, with the child's morphology and things like that, I mean, if he's a you have to look for secondary sexual features, and then you have to. I'm not quite sure about the exact. There are any charts or anything to measure the penile length as such. So for a short urethra, I'm sure there is a standard chart for okidometer for size of the testicle, but you have to judge it clinically to see whether the general penile length is tallying with the child's sexual growth. Pediatric specialists, I think, you have any comments on that? How somebody would say that his penile development is impaired? Or their objective way of doing it?
I'm saying that from the pubic bone to the tip of the penis,
Yes.
stretch penis.
Yeah.
Don't know how because some patients we have to refer for endocrine assessment if it is shorter, but when I don't know when to decide that. So.
Yeah, important thing is that exclude a buried penis. A lot of children come with this, but which was described earlier, buried penis, where there is a mons-like thing, there's fat collection there over the pubic symphysis and the penis is buried. So you have to just press it and find out the exact length, as you said, from the pubic symphysis. And then, of course, the slightest doubt, you send the child for hormonal assessment and things like that to see hypogonadism, exclude hypogonadism.
Yeah, in a full term baby, usually this length from the tip to the pubic symphysis is taken anything less than 2 centimeters. Usually, the endocrine team gets involved and then they do the whole endocrine panel tests and then proceed. And the technique of measuring, what they say is to properly press at the base of the penis so that you get the actual length.
Sanjay, sir, any comments on penile condition? Any questions, sir? Shall we, or else we move to the other topic, sir? We'll move to the last talk of the day. It's going to be on UTI in children, VUR and megaureters. Dr. Dinendra Madhushankar. Over to you, Madhushankar. You have 20 minutes, please.
On few topics regarding urinary tract infections in children, vesicoureteric reflux and the megaureter. First, urinary tract infections in children, which is a kind of common bacterial infections we come across in children, and it has a high prevalence rate, and it can be seen more commonly in female, but still in less than 6 months of age, still incidence is high in boys, and especially incidence is more in uncircumcised boys. And the risk factors for getting UTI, especially recurrent UTIs, are when the child is having associated bladder and bowel dysfunction and associated with vesicoureteric reflux, or in obese children.
Madhushankar, your slides are not moving.
Give me a second. And for this UTI, the commonest causative organism is E. coli. And in our last presentation, we discussed about the pathogenesis of UTI and the pathophysiology of E. coli as well. And then the drawback of having a UTI in children is once they get UTI, they can have a significant renal impairment. And they suggest that first UTI, they can be 2.8% of renal scarring, and with recurrent infections, it can increase up to 25 to 28%. And these urinary tract infections can be classified depending on various classification systems, and it can be classified either depending on site, whether it's cystitis, pyelonephritis, or the severity, whether it's minor UTI or a severe UTI, or septic shock patient, or depending on the episode, whether it's first episode or recurrent UTI, reinfections or a recurrence, and when the symptoms, whether it's symptomatic or asymptomatic bacteriuria or pyuria, and when the complicating factors, whether it's complicated UTI or uncomplicated UTI. I'm not going to discuss again because we discussed it earlier as well. And for our management of UTI, what we interest is the site and the severity of the infection. And when we come across a child with UTI, we go through the medical history to evaluate the symptoms, and especially in pediatric population, it's very difficult to get a history. So we have to go by the symptoms as well as our clinical experience. And in physical examination, features suggestive of infection, same time genital examination and abdominal examination is helpful. And investigations will give us a guide to diagnose the condition, where we can use urine sampling, urine analysis, and cultures. So how to get a urine sample in a pediatric group? They describe we can use either clean catch midstream sample, which is a toilet trained child, or else in the pediatric group we can get cleanly plastic bag attached to genitalia. But the drawback is it can have contaminants and false results. And then we can go for transurethral bladder catheterization, which is more invasive method, but the contamination rate is less. At a last resort, we can go for suprapubic bladder aspiration, where the contamination. Yes, sir.
Still, we can't see your slides properly.
You mean, sir, is it the first slide?
Yeah,
only the first one.
Okay. But in my screen, it's
go to
moving.
slideshow, probably it will start moving, I think, if you go to the slideshow.
Then in the diagnosis, after collecting urine sample with these either 4 methods, then we can go for urine analysis, either dipstick method or microscopy or flow imaging analysis technologies. And dipstick we can use for nitrates or leucoelastase levels, or microscopically we can see the organisms. And the definitive diagnosis comes with the urine culture, where we can isolate the uropathogen, and more than 10 to the power of 5 colony forming units per milliliter is suggestive of significant colony forming. And in pediatric population, if we get a clean catch sample or a catheterization sample, 10 to the power 3 to 4 is still enough. Or if it is a suprapubic puncture, any number of organisms is significant in diagnosing. And what are the imaging we are using in children with UTI? And when child is present with UTI, especially if it is not a atypical UTI or a recurrent UTI, imaging are helpful. Ultrasound scan is indicated in 24 hours to identify any exclude obstruction of the upper or lower urine tract. And if it is a kind of toilet trained child, we can go for post-viral residual to assess whether there's any pathology with it, urinary emptying. And EUA recommends this strong recommendation of scan within 24 hours to exclude this obstruction. And there's place for DMSS scan, which is a radionucleotide scan, which used dimercaptosuccinic acid clearance, which is absorbed by the readily absorbed by the proximal tubular cells in the kidney. So thereby we can detect any UTI-related renal scarring. And the timing of the study should be careful. It should be done after 3 to 6 months of UTI, because if we do it during the period of UTI, it can cause false results. And anyway, there will be some changes during the episode. And the other investigation helpful is the voiding cystourethrogram or the micturition cystourethrogram. And it is kind of optimum method to identify whether there's any associated vesicourethral reflux. And we know UR is very associated with UTI in this group as well. And to do this test, we have to prove that child is having S12 urine and It is indicated especially in a child with the first episode of febrile UTI with non-E. coli infection, and if the child is having recurrent UTI, or if a child is having more than 1 year of age with E. coli infection. And they recommend to do with avoiding cystourethrogram. And here's a algorithm given by EUA, where the first febrile UTI we can assess with ultrasound scan. And if the scan is normal with a normal E. coli infection, then we can follow up the child with again repeat scanning in about 6 months time. And if the child is having non-E. coli infection, then we need to exclude other respiratory reflux and we need to do VCUG. And if the scan is abnormal, where there's evidence of upper tract dilatation or any other anatomical lesions, then we need to first treat the condition aggressively, and then we need to assess the child in view of avoiding cystourethrogram and DMSA. And in the treatment, the administration of antimicrobial therapy is the mainstay, and the choice between oral or the parenteral therapy will be driven by whether the patient age, the severity of the infection, and the child's methods of the drug administration, and whether the concurrent vomiting, diarrhea, and compliance, those factors play a role in deciding the treatment method. And the antibiotic type and the duration is based on the local antimicrobial sensitivity pattern and local guidelines. And it is best guided by the sensitivity testing, which is isolated from the urine culture. And EU recommends children with normal function kidney as parenteral agents like probamycin or gentamicin, and with children with abnormal kidneys, ceftriaxone or cefotaxime, and oral agents like cefixime or formiciclovir. But again, these are depend on the local guidelines and local antibiotic stewardship. Duration of therapy, again, depending on the severity of the infection. Simple infections can be treated for a period of 3 to 5 days. And then earlier, the parenteral treatment should be converted to oral antibiotics. And then we can use clinical parameters as well as inflammatory markers to depend on the duration of therapy. And child with focal bacterial nephritis, they suggest to give antibiotic of 3 weeks of intravenous and subsequent oral therapy. And if the children are having associated obstructive system, we need to think of temporary urinary diversion to facilitate recovery of the infection. Once a child is treated with infection, there's a place for chemoprophylaxis, especially in children who are having anatomic abnormalities of the urinary system, to reduce recurrent UTI and subsequent renal injury with renal scarring, and children with bladder bowel dysfunction and vesicoureteral reflux, and children who are having incomplete bladder emptying. Those risk group, there's a place for chemoprophylaxis, and they suggest Cotrim, trimethoprim, sulfamethoxazole, nitrofurantoin, those things as the chemoprophylaxis agents. But the drawbacks of chemoprophylaxis is it again prevent recurrent UTI, but same time it will cause antibiotic resistance and other antibiotic related problems. And regarding PPU, some children who are having to prevent the recurrent infections, most of the children having physiological phimosis as described by my previous speaker, we can treat them with local use of steroid creams, and same time if the children having recurrent UTI, we can consider circumcision as well, but there should be at least 10 children should be treated to prevent one children getting UTIs. And in the follow-up of these children, we need to carefully monitor to prevent recurrent UTI, and their bladder bowel function should be assessed, and the relevant advices should be given to the mothers to prevent recurrent UTIs. That's all on UTIs, sir. Now I move into my second topic, which is vesicoureteric reflux. It is an anatomical or a functional disorder with the potentially serious consequences, such as it causes renal scarring, renal failure, and lead into hypertension as well. And it can be seen commonly in children, about 1% of prevalence. And there's association between the offsprings of parents and same time the siblings. And this vesicoureteric reflux has a high significance of getting UTIs, especially 30 to 50%. And then children from male to female, boys are having more likely getting VUR than girls. And there's clear association between the prevalence of low urinary tract disorders and respiratory reflux can be seen. And the respiratory reflux is a kind of range of disease where most of the respiratory refluxes are resolved spontaneously with the age, and same times some amount of respiratory reflux need treatments. And symptomatic respiratory reflux, they can lead into renal scarring. At present is about 10 to 14%, and they can result in either congenital dysplasia or acquired post-infection damage due to recurrent urinary tract infection. And the diagnosis is mainly, our aim is to identify overall child, not only the respiratory reflux. First, we have to identify the child is having respiratory reflux, same time whether there's any associated infections and the current renal status, and same time lower urinary tract functions. So our diagnosis workup comprises of our medical history, examination, and our urine analysis to exclude current infection and the renal function at the current status. And to diagnose reflux, we can use imaging studies with bladder and renal ultrasound scans. But the gold standard is by voiding cystourethrogram, and we can use nuclear renal scans, DMSA, in order to identify the renal scarring. And depending on the reflux, they have graded into 5 grades. The grading is mainly depending on the level of reflux and the dilation of the pelvic calyceal system. Grade 1 is where the reflux is at the urethra and not up to renal pelvis without any renal abdominalis. Grade 2 where reflux goes to the renal pelvis but without any pelvic calyceal dilatation or phonacial derangement. 3 is where dilatation is moderate, getting pelvic calyceal system dilatation, but phonacis slightly deformation is started. 4 is phonacial dilatation, phonacial deformation also started with moderate dilatation. Grade 5 is kinking of the ureter with severe distortion of the renal parenchymal architecture. And this can be diagnosed with voiding cystourethrogram, and same time DMSA help to identify the patient's already the level of renal scarring. Thereby we can use it as a guide in the subsequent treatment and subsequent follow-up. And newer methods are there where we can use to avoid the ionizing radiation, we can use contrast enhanced voiding ultrasonography as a diagnosis method of respiratory reflux. When we diagnose the patient, the management, mainly it is conservative management with non-surgical techniques, and there's a place for surgical aspects as well.
Madhushan, can I have 5 more minutes, please?
Okay, thank you, sir. In non-surgical therapy, mainly we know that most of the patients who are having grade 1 and 2 reflux are resolved spontaneously in about 80%. And these grade 4-5 patients still having a significant level of resolution. And this spontaneous resolution is low when the patients have bilateral high-grade reflux. And same time, in the conservative management, we can closely follow up these patients, and we can use either intermittent or continuous antibiotic prophylaxis, and same time bladder and bowel rehabilitation. Those are the mainstay of conservative management, and circumcision can be considered as well. And follow-up can be done using these imaging methods, and same time in that follow-up, you have to make sure UTI should be prevented and constipation and bladder pain, those should be maintained. And regarding antibiotic prophylaxis, they have proven that continuous antibiotic prophylaxis has reduced significant UTI, thereby reduce the renal injury. And we can use these antibiotics for prophylaxis. And it is tested with this RIVER trial, where it has shown that it reduced the recurrent UTI about 50%, and it will reduce renal scarring and its consequences. But still, the antibiotic-related problems should be considered. And surgical treatments can be endoscopic injections of bulking agents or urethral reimplantation. These bulking agents, as I discussed earlier, there are a lot of methods, lot of things in the market, but proven one is the PTF. Still, it is not recommended in EUA because of its having particle migration. And it has success rates, and we can use either repeatedly, and in all the grade patients, we can use those agents as well. Then open surgical techniques are there. there are either intro or extravesical techniques we can be used, and there are different methods have been used, and a few methods are there. Most popular and reliable method is we can use cross-trigonal reimplantation, which is described by this Cohen, where the ureter orifice is cross to the trigone and reimplant to the contralateral side. And there are other suprahiatal as well as infrahiatal techniques. You can go through in these diagrams where these techniques has been described. The polytenol lead butter technique is suprahiatal, and this Gray-Anderson technique is infrahiatal. And then that is mainly of vesicular reflux. And bit about megaureter. Any condition which denote dilatation of the ureter, irrespective of the cause, is known as megaureter, and it could be either primary or secondary, depending on the causative factor. And they have described 4 types. They can be refluxing megaureters, obstructed, non-refluxing unobstructed, or refluxing obstructed system. And a lot of causes are there. And this obstructed refluxing megaureter is a condition where the ectopic insertion of the ureter, where the filling phase will cause, there will be obstruction, and the voiding phase will lead into reflux. So they will have obstructed refluxive ureters. And again, this megaureter is a challenging situation where some patients will have really obstructed system, which leads into renal impairment. Those children need to be identified and treated early. Whereas the other patients who are having only this dilated system but no functional abnormalities, they don't need treatment. So we have to balance between these 2 groups. And bit about primary obstructed megaureters, a condition where pathophysiology is not well clear, but they think that terminal ureter is having adynamic segment leading into obstruction. So again, boys are having much more affected, and these children also need to be treated because this dilatation can lead into recurrent UTI, stone formation, and renal scarring and symptoms. So surgical management should be considered if the patient is symptomatic, having UTIs and progressive damage to the system, and differential function getting down less than 40. So again, before treating, if the patient needs prompt decompression, we can use either nephrostomy tube diversion or a distal cutaneous urostomy. But in pediatric population, nephrostomy tubes are a bit cumbersome, so they suggest for distal cutaneous urostomy. And surgery is mainly, we need to make the ureter, the distal length of ureter remodel in order to make a good ureter to prevent reflux. We can use either plication method or excisional tapering of the distal ureter. Same time, we need to shorten the ureter in order to straighten it up. And we can reimplant it by using either suprahiatal or infrahiatal or extra intravesical method. And the outcomes, most of the techniques may make a good outcome. And but still, sometimes, though we do a good surgery, worst outcomes can be there if the patient is having bladder dysfunction association, or else they will have urinary tract, lower urinary tract problems, and such as PU valves or obstructed flow. And these surgical problems, so surgery also can complicate later on with either they can have obstructed or VU reflux again or persistent dilatation. These are the references, Campbell and EU guidelines.
Thank you, Madhushankar. We'll move to the panel for discussion.
Yeah, thanks. So the VU reflux, as you said earlier, so I think we had a little chat about these grade 1, 2, which most likely will resolve as the child ages. So if he is diagnosed before 2 years, certainly you would be waiting for 2 years. I think Taranga was mentioning, I think lots of the urologists in UK and those countries where deflux is available, that's a dextranamab of hyaluronic acid. Is that right,
Yes.
Taranga?
Yes, sir. Yeah.
So,
Yes.
so that is, I think, is reported to be safe, at least at the moment. So only these problems will crop up in time to come, if there is any, but hopefully it should be okay. It's a bulking agent. So that basically the idea is to narrow the lumen and lengthen the intravesical ureter so that the reflux is less. And you might need repeat injections, I suppose. No, it's like not a permanent.
Usually, like they do two, like there's a hit and a sting. The hit is done within the ureter, and the sting move outside to form a mound And at the same time, you should do it not to a degree to obstruct you. After the procedure, we visualize the urine being freely flowing from the ureteric orifice as well. Usually one hit and a sting would do, but some children come for repeated procedures, but not a lot. And at the moment, there's a trial going on in Great Ormond Street where they're doing it with a lot of other European countries as well. So hopefully the results will be out and we'll have a better idea of the long-term outcome. Yeah.
Okay, and then the grade 4 and 5, again, I think they use sting. There is no contraindication, I mean, for the injections, but the success rate probably will be low, and then there is probably slightly higher need for the ureteric reimplantation. And I think the methods, as you said, the Cohen or the Ledbetter Politano and Glenn Anderson, I think. Yeah, so the majority of the time we use the cross-trigonal, the Cohen procedure if there is a need. But for reflux, we actually do less and less, and very few actually. But most of our replantations are actually for VUJ obstruction and the megaureter. So the syndromes associated, like the Poon-Belly syndrome, about these non-obstructive, refluxive megaureters sometimes. That's mostly seen in neuropathic bladder, I think. Yeah. So, anything to add, Saranga?
And not really. So, actually, for VUG obstruction, again, here most of the pediatric urologists do the cutting balloon, which has quite a success rate. But with that, we've seen secondary reflux.
Reflux.
Yes.
Could I ask a question? Yeah. Sorry. Yeah. Go ahead. Yeah.
No. Carry on, sir. Yeah.
Just a simple question. Now, how long are we advising to continue prophylactic antibiotics once you have started it? What's the duration of it?
Yes, so we leave the decision with the nephrologist usually, but I think 5 years is the rough time period that was used earlier. But I think the nephrologists at LRH, at least, I think use it now for shorter and shorter periods because they have found, as you said, that grade 1 and those very minimal reflux, there is no real much higher risk of UTIs also. So it's a problem of the having compliance and then some of these unwanted side effects like nausea and various things. And because it's not an easy thing to give to a child a medication every night for years. So but
old paper to show that our time, I think that 8 years, up to 8 years, the scar formation is more, and after the 8th year you can stop it. But I don't know whether that same guideline is there now. But the duration is a little obscure, when to stop.
Yes, and it's becoming a little bit shorter and shorter, and particularly for the very low grades. Yes. So the moment the child is able to say that, okay, I have symptoms of UTI, kind of, the child, if he's mature enough to get it, so then you can immediately start treatment even before culture, then anything comes. So some people even advise take a urine sample, start the antibiotic at home, and then come and see the nephrologist or the urologist or whoever.
And also the duration depends on whether the bladder is neuropathic or bladder is dysfunctional as well, because dysfunctional bladder will take a longer time to settle, isn't it? And regarding these reimplantation techniques, Cohen will be difficult in a megaureter, isn't it?
Yes, tapering.
Tapering, that's Parkwin's method, they call it. So that will have to do. I think we generally use for adults extra extravesical Lish-Gregoire technique. So and one more thing, should we combine this with reduction ureteroplasty as well? Suppose it's a very long ureter, megaureter, and dilated tortuous ureter. Should we combine this with
you mean shorten
reduction
the ureter?
Yeah, shorten the ureter.
Yes.
So otherwise, what we have found is that acts as a reservoir and collects sort of urine there before it drains down, isn't it?
Yes, you tend to straighten the ureter as much as kind of you can, but basically you might end up almost, so you have to be a little careful that you might
when you straighten it up, it comes up to the knee sometimes, the child's knee, so long, so lengthy ureter.
but definitely redundant part needs to be excised, I think, for it to have any.
Yes,
yeah.
because.
And about the little, I think I have unmuted my mic while doing that hyperspadias thing. Just a little adapt the the treatment. I mean the classification and all those things are fairly straightforward. And out of the three, the chordy is the most difficult part to correct, particularly if it is intrinsic chordy of the corpora. Skin chordy, bulbous sponges, all those things are pretty easy. And the majority of the penile hyperspadias, we use the anatomical repair, the technique called anatomical repair, where we put back all of them. Like, so you start with the urethroplasty, then we bring out the divide or split spongiosum together in the middle for the spongioplasty. So right up to the, and then it becomes the glanoplasty. Distally, the spongiosa becomes the glands. And then we will bring the dartus fascia on top of it. And then, and also that spongioplasty will correct the glands tilt and a little bit of the chordy kind of thing that is usually associated with that. And then we bring the prepucioplasty, and then onto that the callus fascia or the dartus fascia, and then bring the skin usually in a subcuticular suture so that it gives very good cosmetic results. So anything, the penile shaft hyperspadias, and if there is no intrinsic chordy or where you don't have any corporal discrepancy, then that is the treatment of choice. And all these other methods are mainly for proximal, the BRCA procedure. So BRCA is associated with these glandular detumescence, or erections don't, the glands become soft even during erections when they are old. So that's one of the drawbacks of, so you only do it when it is really needed and very short urethral plate. Yes. So anatomy. Is that the case in great osteoarthritis, Aranga? The hyperspadias repair, what are the techniques that they use for mainly penile hyperspadias?
Basically, so they completely deglove the penis even for a mid shaft, just to make sure that the chordy is completely released. And then it would be the same repair as ours, yes.
And for the distal hyperspadias, do you do snot grass, or do you put a graft, incise plate, snot graft they call that? Do you use the technique anymore?
If you use the graft only if the incision on the plate goes very close to the urethral meatus. But if it is more proximal, then majority do not need a graft, like a little, it's like a little canoe kind of graft, but we rarely use that. But the majority of the time, we do not do because snot grass involves that preputial curtain. So you get rid of you throw away the preputial, the dermis and the epidermis, and use the dartus fascia on it as the covering. No? So then you lose the foreskin for any future, if there is a like a breakdown or whatever, then you lose the foreskin. So you use the dartus fascia within the foreskin and then use it to do the prepucioplasty and the anatomical repair. So I mean, I think LRH, everybody at LRH for anything proximal shaft onwards is anatomical repair. But then if there is chordy, you can really deglove it and mobilize the penis right around actually. And then I can go ahead with the repair. And majority of the chordy is skin, and then the bulbous sponges, the muscle, tethering it, as if the scrotum is pulling it down, and then the fascial chordy. So once you release them, a great majority, the chordy will become, the penis will become straight and not bending down.
Has a buccal mucosal graft any place in pediatric urology?
Mainly, we use that mainly for salvage. If we've been repaired a million times, and then like what do you call earlier it used to be called the hyperspadic cripple. No longer used in open this thing because it's like a derogatory kind of step. But what it means is that it is a patient who has been operated so many times, and there is hardly any foreskin, hardly any soft tissue. So there is no grafting. So buccal graft is used in that situation. Very rarely do we use the buccal graft as the primary thing if the foreskin is intact and sufficient. But if the foreskin has, like a BX, some other issue, then certainly, yes, the buccal mucosa becomes the next best kind of situation. There was a time where we thought our buccal skin would be even better than this thing. We started doing that, but then we found that has a little bit of it contracts sometimes a little bit more than the the non-keratinized inner prepuce. So now we're going back to but now we do less and less buckles after we really become proficient in the anatomical repair. We have found that we need less and less bracas also. Braca, although it looks very nice at the end of the procedure, long-term results have been a bit of a problem. And particularly when you don't have this spongiosum around the urethra, this ejaculation, and sometimes the urethra becomes like a megalourethra almost. And, patients complain of dribbling after micturition because it doesn't empty very well. So you have to squeeze the urethra and a lot of problems, especially if it is extended into the penosporal junction area. So those problems are mainly avoided by doing a good anatomical repair where you bring the spongiosum and the bulbospongiosum muscle also in the proximal penis together, and then the colossus, it's like putting back the anatomy back into place. So that has fairly good results, functional results. So that's the more important thing, I suppose. Actually, a little slight cordy, which is, if you don't have to have a penis like an arrow, I suppose. So, anything 10, 20 degree mild cordy is not a big issue, but what you need is a more functional penis. So that would be achieved. That's what the Manchester group or the people who advocate anatomical repair says. So, especially if the parents are pretty keen on having the foreskin and not a circumcised appearance, then that's added advantage as well. So, anything, Taranka, anything to add?
No, so I think, that's almost what is done at Great Ormond Street as well. A lot of people don't like circumcision due to cultural reasons, and they sometimes request here. Here they have more say on what they want, and they sometimes request here not to have a circumcised appearance at the end of the procedure. So
only the Muslims and the Jews will want it. Everybody else will want the food. Okay, I think we'll get on to the next topic then.
It's all done for the day, sir. I mean, we have 5 talks and discussions. Actually, we have run out of the time. Also, it's 9.
Oh, really?
But we had a good discussion, sir. We had a fruitful discussion on topics. We have covered almost all the pediatric urology topics. Thank you very much, everyone, especially our...
I think all the candidates have prepared very well, actually. I mean, there's very little to add except a few kind of practical things. And also the hyperspadia is one thing is that it is not for the occasional surgeon. Even the most distal hyperspadia sometimes can be a bit tricky and bit of a nuisance if, because it's something which is, you can't hide your complications. So it'll be very apparent to at least the parents and child. So not to the public so much, but then because of that, so it is from a practical point of view, not from the exam point of view, it is something that takes time to master. So not for the occasional surgeon for sure.
It's very important because if that is not done at the LRH properly, then they will end up with us, when they're adolescents and adults. So we come across number of them, so we complete the picture. So I think you are absolutely right. I think it's a specialty by itself. I think somebody has to master it more and more. You have to do.
So that's why the pediatric urologists are that is necessary really to have, particularly more than the hyperspadias, of course, the other issues of these, the bladder, other pediatric, more complex urology issues, but even hyperspadias is a demanding. Our parents are not so demanding, so people get away with.
But you never know. I think
it will become like that.
Society is becoming very litigated, so I think they we might face problems. I think we need a pediatric urologist. So that's a different topic. I think we have to discuss at length, more sooner than later.
Okay, so nice. Thank you, Taha, for inviting us. And thank you, Taranga, very much. I mean, so she's...
thank you so much. I enjoyed the session despite the jet lag. So thank you so much for inviting me.
Before we wind up, there's an announcement from Slaus, Secretary Slaus. The closing date for MCQs would be on 31st of this month. So the candidates are requested to send you application forms before that closing date. And I think we have come to the we'll come to wind up the session. I would like to thank the expert panel, Dr. Sanjay Abegunasekar, the pediatric surgeon at LRH. And then, even though the Prof. Navil sir is a participant, thank you for your input, sir. And Dr. Taranga Dilrukshigamagi, despite of your long travel back from UK, we thank you for your experience or sharing your experience at Great Ormond's Hospital. And all the speakers, you have done the presentation nicely. And then my co-moderator, Dr. Munipriya Villararachi, for moderating the session. And for the last, not for the least, our sponsors, CIPLA, for organizing this online teaching session. So I wish I have learned a lot, and hopefully we all learned or discussed many things in pediatric urology. And we'll meet next week in next Uromet session. Have a good night and a nice weekend ahead, sir. Thank you.
Okay, thank you very much.
Bye.
Good night.